So when you don't respond back after lunch, it gets us jittery, you know. So anyways, me and Simran will ensure that after this session as well, we are in energy and we don't get into our slumbers. With that promise, we'd like to get into our next session. You see, this next session is titled as Tomorrow's Baby, Technology, Ethics and Identity. Now, as we talk about the future, and you know, it is this one is going to be about future and philosophy kind of amalgamated into it, where science isn't just innovation, rather it's also about intention to get it right. So now, anyways, in this session, I briefly want to take you through is going to be speaking about an era where assisted reproduction no longer just supports parenthood, it rather redefines it. From solo IVF and single parenthood by choice to gene editing, embryo selection, and stem cell enabled fertility, the possibilities are really expanding. Our previous panelists have also touched upon some of these factors slightly, but we'd possibly be getting into much more detail in this one. And this session, of course, is very future relevant also for all of us. So without any further ado, I think we'll get into by inviting in our panelists to join us in.
Definitely, Kanishk. So now I would like to invite experts for panel discussion. Dr. Reshma Dhillopai, President-elect of the International Federation of Fertility Societies, former President, Indian Society of Assisted Reproduction, former President, Foxy, consultant gynecologist Leelavati, Hinduja, HN Reliance Hospital, Mumbai. And we need to welcome our speakers with a round of applause, with a huge round of applause. We just had lunch and the energies are high, I believe. Dr. Suvarna Khadalkar, Professor and Head of Department OBGYN and Consultant Endocrinologist and Gynecologist, Bombay Hospital Institute of Medical Sciences, Mumbai, Secretary General, Foxy 2527. Dr. Balasaheb Khatbade, Chairman and Director, Yashoda IVF, Mumbai, Director and Postgraduate Institute of OBS and GYN, Yashoda Hospital, Navi Mumbai, Program Director, MUHS Fellowship and Reproductive Medicine. Dr. Ritu Hinduja, Clinical Director, Cloud9 Fertility, Mumbai. Let's welcome our speakers with a round of applause. And to lead this very important discussion, we are pleased to have with us Dr. Kuldeep Jain, Director, KGIVF and Laparoscopy Center, Founder, Secretary and past President, Indian Fertility Society. Let's welcome a set of speakers with a round of applause and let's get ready to hear them. Over to you, sir.
Thank you. So dear friends, I hope you will remain awake after having this lunch. We will be talking in next 30 minutes. I will like to tell my panelists and audience that because of shortage of time, we will be binding up in 30 minutes instead of 40 minutes. But we will try to cover almost everything what we wanted to cover in 40 minutes. So I will like to have crisp answers because we are having a lot of questions which needs to be dwelt upon. So as the topic of this panel is tomorrow's baby, we are sitting in 2025, so we will be talking beyond 2025. But having said that, we are going to consider the facts. That is very important because if it has to be a relevant discussion, then whatever is available, that has to be kept in reality perspective. So whatever discussion we are having, we like to have some sort of consensus on the future. Okay, and here we are having expert panelists. So I believe that we will be able to give some key messages to audience. We are going to talk about the future babies. And you know the society is changing. We are having 4-5 factors which we have to consider. Science is there. Science is evolving very fast. Then there is the society. It takes time to keep the pace with science because it is a amalgam of very old generation, medium generation, and then present generation. So it takes time, but certainly present generation is again changing very fast their perspective as far as the family is concerned, life is concerned. So that is second part. Then third part is our regulators. They take back seat and they change very, very slow. And fourthly, we are clinicians. Now, we always take science, society, and regulation together. And it is our job to keep the balance in the society. If you talk to new generation, they don't want to marry. What to ask about the kids? They don't want to marry. I have spoken to so many people, especially who are in IT sector. The marriage is not in their agenda. Maybe 10 years later, they will like to have baby. So that is the current generation we are facing. So when we talk of parenthood, now we know that marriage is in India especially, we are having an institution called marriage, and then family comes. But present generation is asking to have baby without marriage. So reproduction by choice. That is the first topic which I am going to deal with. Single parenthood. I will not say single motherhood. It is single parenthood which we need to discuss. Because again, the legality comes when we talk of single parenthood. And things are not very clear. If you see the data, I could not find Indian data that how many people are opting for single parenthood. But there is some data available from US, and that is the biggest population where the single parenthood by choice is there, 47%, and out of that, the black population is very high single parenthood. There is another data from Cryo International Bank, because they are having data that 54% of the people are asking for, when they are asking for egg donor or sperm donor, they are single mothers, single parent. Okay. But in India, maybe our panelists will focus more on the Indian scenario. So, Dr. Rishma, you have been in this field of infertility for quite some time. What is your perspective when we talk of single parenthood? Is it changing recently in India? The demand, is it rising? And what type of people are coming to ask for the single parenthood? Second thing I will like to ask you, what are the challenges you face? Because it is not that simple when you talk of single parenthood. And what is the legal status of single parenthood in India?
Thank you, Kuldeep. Good afternoon to all of you. I'm so glad that all of us have gotten together to discuss some burning issues which are happening in reproductive medicine today. One such issue is of single parenthood. So let's start first with the legal aspect, because that is what has actually brought about a significant change. So we all know that with the ART law, the technology law which came in 2021, where they officially allowed a single woman to become a parent out of choice. The law did not include men. So single men cannot have a child of their own through ART, but a single woman over the age of 21 can. It also expanded upon the surrogacy law, and a Indian married heterosexual couple can ask for surrogacy, can be offered surrogacy. Even widows as well as divorced women as single individuals can have surrogacy. Again, the men are excluded from this choice. And so there are legal implications. It is allowed, but later on, has the law caught up? Once this child is an adult or grown up, what are its rights? What are the inheritance? What are the, when they go for a passport or when they go to school for the school leaving certificate or admission, is it all sorted? That is still a question mark because the law is relatively new. So having talked about what is allowed in this country, let's go to the other side. Is it ethical? So I, as an individual, have reproductive rights. I own my, I have the autonomy. I can decide what is best for me. So also for the men. So I have the right, I have the choice. The law is allowing me. So it is ethically right for me to go ahead. But is it okay for me to bring a child into this world which is not yet, question mark, ready to receive a child or to accept a child and nurture a child which is born out of a single parent, single woman rather. So that is an ethical dilemma, and I'm sure that is what inhibits a lot of women from having a child. Lot of single women must be yearning to have a baby, but this kind of keeps them a little bit worried, scared, concerned. The second thing is about surrogacy, about anonymity, about donor anonymity. You know, in India, I don't know whether it's a good thing or otherwise, I think it's good, that the donor, whether it's an egg or a sperm donor, is kept anonymous. And that is great because today a girl can go to a bank, get sort of a selected donor sperm, and she can go ahead and have a baby, whether it's IUI or IVF. And the man who is the donor is anonymous, nobody knows who he is, and he has no rights over the child subsequently, which is a very sort of feeling of safety, because you don't want 5 years later some man to come knocking on the door and say, this is my child, which is happening in the US. In the US, it is officially open knowledge. There's a registry of donors. So I hope, or we don't know whether our country will go that way. Maybe after 10 years or 20 years, we don't know. So these are all the ethical dilemmas. And the biggest problem is societal problem. Society has not moved as fast as medicine has. Medicine has progressed by leaps and bounds. Society is still bound by traditions and religion and cultural, and our family doesn't do this, and our culture doesn't allow this. And so when you bring a child into this world, the woman is definitely having a strong risk of being discriminated against. I don't know how society will treat her. Her own housing society may say, oh, we don't want single women to be in our building. Or the school will say, oh, we don't want single women to enroll their children in our school. Families may disown the girl, and I have seen this happening. So there are a lot of issues which the mother, intending mother, will face. And the child, probably even more so. Because school admission, the children may sort of ridicule the child, you don't have a father, and how will the child be brought up by a single parent, and the passports, and again, school admission. So it's a huge societal thing, and there's a lot of discrimination.
So it is not only the ethical issue,
Yes.
there is social
social issues.
At present, I think you rightly highlighted that point. Yes, as far as the human, the reproductive right is concerned,
Yes.
it's good. And we cannot suppress it. But when it comes to, because the boy or girl, whosoever is born, will be in the society only. They will be
They'll have to
developing in the society. And I
also
think
I
that
think-
is one thing, when we talk of having single parenthood, I think that is our role as a clinician. Before providing the procedure, whether it is IUI or IVF for that matter, counseling of these parents is very, very important. I think that will go a long way from which society the person is coming. how they will be managing the pressure. And so what do you feel, like how do you counsel, means if a person is coming to you for single donor, you just provide it, the procedure, and your job is done? Or there's something more
I think
when you are
we have a
providing these
huge
services?
responsibility because unfortunately India, even the financial setup is not great. Insurance, provision for the child, long-term welfare, we don't have any of those schemes. Right? So that's a financial issue. Mental support. None of us have our, therapist, like in the US, everyone has their personal therapist. We don't have mental support. The girl might feel isolated, she might feel lonely, emotional distress, financial problems. So who's going to be supporting her? So let me give you just two examples of what is happening yesterday. Day before I delivered a single mother. Okay, she has an older sister, and throughout the pregnancy, she has come only with her older sister. They're very close. They have an old mother at home, and this is the family. She's just given birth to a daughter. I don't know what she wanted, boy, girl, I have no idea, but she's given birth to a lovely daughter. And the support system is very strong. She's well-to-do. She has her sister with her every single antenatal visit and in the hospital right now where she is. So those kind of families, I think, she's in her mid-40s, the girl. So those kind of families, I think, can bring up a child well. They're very forward-thinking, and they're very financially independent, and support system is strong. I have another girl who's from a filmy family, Bollywood filmy family. She's divorced. I did her egg freezing while she was married, but she knew that she was having problems with the husband, so she didn't freeze embryos, she froze eggs. Now she's divorced, and she's come back for having a baby without the husband with the eggs that we have frozen. So these are like very recent examples happening with me now. So I think there is a lot we have to do: counsel, support, financial, see that they are secure, and only then go ahead and offer them. The technique is easy. Every one of us can do it. But it's just that should we? So just because it's available, should we? India has moved forward medically very rapidly. Society has not caught
Moved,
up.
yes.
Has not
That is the point which I wanted to bring to the discussion.
Yes.
That though we are having very fast growth as far as the technology is concerned, but we are stuck up in
Religion,
as far as the
conservative
society perspective
traditions.
and other things. So there are more questions, but we move on to the next question, and if time permits, then we'll come back
For sure.
to this. Now, another point which is we are, as a clinician, we are facing, and I think that everyone on the panel will agree that we are having a change, shift as far as our patient population is concerned. We are having patients in elder age group, and even in younger age group, we are having premature ovarian insufficiency. You don't see any egg, whether it is young or... so the amount of population is increasing who are facing a dilemma that they want to have their own child, but the eggs are not available. And we have been talking for long about stem cells, that they may be the thing of future, that we will be able to generate artificial gamete by stem cells. Even the endometrium, we keep always struggling. So that is another advance which has come, but again there are a lot of ethical, legal problems as far as the stem cell application in clinical scenario is concerned. So Dr. Subarna, what is your take on stem cells? What are the ethical and legal issues as far as the stem cells are concerned in our practice, clinical scenario?
To be very frank, I don't practice IVF. So stem cells and other things, actually, if you ask me my personal view and what is going on, so far, I think there is no official ethical permission to use the stem cells for IVF purpose. That's what my knowledge tells me. But I think it's thing for tomorrow, as you rightly said. If not today, as we develop, the stem cells are the ones where they are going to enable women to have their own child after having menopause or after having premature ovarian insufficiency, as you rightly said. But today, I don't think I can really much give opinion that what is the scenario that we are practicing today, but I'm sure it will come in future.
Dr. Ritu, will you like to comment
Yes,
on?
I'd like to chime in here. Yes, we do have a technology which is developing. There is a scientific progression, but at the same time, there is ethical dilemma attached with it. We still don't know what is the transgenerational effect of these technologies. We're still to witness that. There are centers which are offering it, but yet we've not seen babies of the women or the girl children or the boy children who have been born through this technology of ovarian rejuvenation per se. Rightly so, when you said that we are seeing a shift in our patients, where we're seeing lower ovarian reserve, where we are seeing premature ovarian failures coming to us. I think it's a wake-up call for us as a society and as a scientific community that rather than banking on technologies which still have a lot of gray area, we have a technology which is present today, which is oocyte freezing. We know that we found microplastic in ovarian fluids. We've found endocrine disruptors in blood hormone assays. This is the time that we need to create more awareness, and I would like to take this platform to create this awareness about egg freezing, because that is something that will help our future generation, because we are removing the oocytes, we are removing the gametes from that environment where they are constantly being exposed to these detrimental factors. Why would a woman need stem cells in the future if today she has frozen? This is the best form of preventive medicine
I think that is another area which we need to dwell upon, maybe not today, but certainly because egg freezing is one thing which
really
again having a lot of, we need to generate a lot of awareness, lot of infrastructure. It is not available everywhere. So all these technologies, they will take time.
No, I think Dr. Khudeep, when there was anemia, we as a doctor society took it upon ourselves to create that awareness, right? When we created that kind of infrastructure where women were not suffering from anemia anymore, and we're still fighting that battle. Rishma ma'am is still creating a lot of awareness about anemia in women. We are creating awareness about menstrual hygiene. Then why can't we as a doctor community create awareness about egg freezing and telling them that it's best to do it today than wait for tomorrow? And I think it
correctly said.
Just a very quick comment. I agree with you that egg freezing is viable today, acceptable, available, inexpensive, and affordable. So it's there for us. But let's not write off platelet-rich plasma infusion into the ovary. Many of us are doing it. It's question mark for research only right now. I believe stricter laws are coming in where they may not allow us to do it any further. But it's a good technology. Stem cells are being used across specialities, and it's here to stay. Not only that, ovarian, removing the ovary, rejuvenating it outside the body and putting it back is not experimental. Children have been born through that technique. Also creating sperms and egg from skin cells. So dramatic. You take a piece of skin and you can sperm out of it. And that is again there. It's happening in today's world. And so technology is there. It's going to advance. You can't stop it. The law is obviously behind.
But again, when we talk of clinical scenario, we must give a message here that we see a lot of people advertising that we are doing stem cell therapy. For here, as far as the clinical use is concerned, it is still research. It can be given only in research setting, not in general setting. So that is one important thing which I would like to highlight here.
I look at egg freezing, embryo freezing as a way of women empowerment.
Yes.
Because, today women are going to go for their careers and they don't want the pregnancy to come in their way. So many women who want to pursue their careers, they are going for this. And I'm sure all the IVF specialists are creating the awareness for the same. So many women who are going ahead in their career, they do opt for this. And when a right time comes in their life to have a baby, then they use this as, they're having their own babies later on. So whatever technology we have today, put it to use fully. And of course, the research will one day be available to us in practical use. Then that's a question of tomorrow. Yeah.
Okay, so we move on to the next advance, which is actually much more in the news rather than in clinical setting. That is gene editing. We see a lot of news in paper that gene editing is available, you can have designer babies, and so on and so forth. But when we talk of technologies like CRISPR, which is by which we can actually do a lot of things, and that has been used for gene editing, there is a very thin line when it comes to reproduction. And you may have a lot of demand once the technology is available that I want intelligence of this one, looks of this one. And so there is a thin line whether technology, whether it is CRISPR or other gene editing methods, to be used for reproductive purpose, to selecting the genes, how your baby will look in the future, or it is to be restricted only to the therapeutic use. So that is again very big question. So I will like to, Dr. What is your opinion as far as the gene editing and CRISPR is concerned? How much ethical issues are involved? Whether it should be used for reproductive purpose or it should stay in the therapeutic role?
This is a very interesting question. And as far as India is concerned, we have been regulated with our ART law. There may be more advances in the genetics. I think genetics is still in the infantile stage. So there are many technologies and gene editing and many things are going to come in the genetics. But right now we are having whatever the, I think 200 diseases are screened in the PGT. And whatever the diseases like cystic fibrosis, thalassemia, and these are the rare patients, but we can benefit them of this technology. As far as this designer baby is concerned, see, I'm practicing in New Bombay. Recently, we started one clinic in South Mumbai. So we are coming across those patients. One patient asked me last week, I want a blue-eyed donor. I told, okay, all right, but the thing is that according to the availability of the volunteer donors through the ART banks, you may get a chance to have, but we can't guarantee. And the thing is that such demands are going to come more. Maybe next generation of the IVF specialist will face more dilemma like this. But with the technology, there are the disadvantages also. So we have to be in limits of the medical ethics and the legal things in India. See, we are, as a clinician, we are the custodians of the ethics. So we have to follow ethics, we have to follow the law of the land. And then accordingly, we can guide our patients. We have to fulfill the expectations of our patients, but within the limit of the ART law. So presently, we are getting different scenarios, getting a very complex scenario. As Reshma madam has mentioned, one patient had frozen eggs, and then again she got divorced. So many complexities are coming. So live-in couples are coming, we want a baby. So if they don't have a marriage certificate, we can't process There is a legal provision that they should go through a ART bank, and the living partner, male partner, can route sperm through ART bank. So whatever the expectations of our patients are there, we have to frame it in a legal perspective, and then I think we have to align our ethical compass to align such a way that we can have a dignified human life, and rather than going to a ideal genetic baby like that.
Very well said. Actually, this is one area where the technology can be used as well as misused. And in India, the scenario is if it is not regulated, it will be misused much more, because we are not very used to regulations. And when regulation comes in India, it is either all or none phenomena. So at present, Indian law is very, very clear. You cannot do gene editing for on-demand purpose. Like, you can use these technologies only for therapeutic purpose. And again, there is a lot of risk involved, especially the hereditable diseases which can be transmitted through this technology. So again, ethical questions are there. At what point you should stop? How do you, Dr. Ritu, how do you see the clinical community drawing boundaries between treatment and enhancement? One is treatment. You require gene editing to prevent certain disorder like sickle cell anemia. You can do that. But a request comes to enhance the future generation. So how do you draw the boundaries? Means, because there is a role of clinician here. So how do you see that what clinicians should do and where they should restrict the use of these technologies?
So I feel that technologies like CRISPR and gene editing are a welcome change, because they can, help us stop the progression or the passing on of the gene with the particular disease. So I think that is what it should be limited to. As a community, we should make sure that's used for medical reasons rather than cosmetic reasons. So that is what my stand would be. But I'm sure if a technology like this comes in, there would be a law which will come in and follow. So we will follow the law of the land.
We are already having law. Dr. Suvarna, as a Foxy leader, you are a leader, you are having exposure to almost 40,000 plus gynecologists. What is your message? Because, see, our community needs to be taught. They need to make aware. We need to make them aware. So what is your message to Foxians?
I think the message is very well said by all of us, that the awareness has to be created. What I can do as a leader of 46,000 members is go to individual member bodies, and we have a module on all this, whatever we discussed today, regarding the laws, regarding the techniques, regarding the ethics. All we can prepare a module for training and educating all our members, and I'm sure our the entire Foxy leadership can help going down to different. We have 286 member bodies, so we can kind of go, and today we have another technology after COVID, that is Zoom. We don't even have to go physically to different cities, so over Zoom we can teach and educate all our members regarding what is the current scenario, because we don't want our Foxy members to fall in a trap of doing unethical practice.
Yes.
And then all that comes to the head office that, see, this particular member has done such a unethical thing, please take action. But we are nobody as a, we are not the appropriate authority to take action, but our job is to educate each and every Foxian. That's what I feel.
Okay, so actually our time is up, but I will just like to conclude. We should have 10 more minutes to conclude. But finally,
Can I give one message?
yes,
Because
yes.
as an endocrinologist, as a basic infertility specialist, I have a message to everybody, all IVF specialists. I think first, please start and explore all the basic infertility modes of treatment, because I see a lot of IVF being done too early. You know, maybe you have to wait and explore every possible other way to treat infertility. If they are all, you know, exhausted and they're not helping anymore, then only we should go for IVF. And there are so many things which are treatable. So treat them first, give them a basic infertility treatment, and if they don't, then go for IVF. I think that is what I would like to see.
So, just a concluding remark from all 30 minutes discussion. We cannot stop science. It will keep on evolving. We have to, as a clinician, work under law. And Indian law, ART law, adopts a precautionary approach, permitting genetic intervention only when essential for preventing hereditary disease. India's ART regulation emphasizes that reproductive technology should be used as a medical solution rather than a tool for human enhancement. That is the current scenario. It may change. As the field of ART continues to evolve, as a clinician, we should have a holistic legal and ethical discussion will be crucial that will be shaping future policies and ensuring equitable access to such advanced technology. So our job is work under the framework of ART for law and keep on discussing these topics, and whatever comes is better for our patients. We had to tell the regulators that, look, in the morning also there was discussion that ART revision, we are facing a lot of issues. So that is our job, the IFS, ISAR, FOXY. We need to unite again and tell the regulators that this is not in favor or this is in favor of our patients. So with that, I bind up this panel. And thank you once again, all panelists. You have done a wonderful job. And I believe that we are able to give some key messages to the audience. Thank you very much.
And thank you, Dr. Jain, for trying to wrap this up in 30 minutes. I know it has been difficult. Thank you so much. If I could please request you to kindly extend a token of our gratitude to Dr. Rishma Dhillon first.
Let's have a round of applause for our speakers.
We'd like to thank Dr. Rishma for her contribution and being with us. I would further request Dr. Jain to hand over a small token to Dr. Suvarna Khalkar. Thank you very much. Thank you, ma'am, for gracing us with your presence and giving in time. I would like to request Dr. Jain to hand it over to Dr. Balasaheb Khadbade. Thank you, sir, for taking our time and being here with us and sharing your insights about the topic. And we definitely request you to keep your hands rolling as I further request Dr. Jain to extend our token to Dr. Ritu Hinduja for being part of this session and concluding this wonderfully. If I could also please invite Dr. Pankaj to please step forward and hand it over to Dr. Kuldeep Jain, as we also thank him for conducting this session so wonderfully.
Let's have a round of applause.
Brilliant. And if I could please have all of us together as well for a group picture, please. Please join us in. Ladies and gentlemen, this is your cue. Let's give it up. Let's give it up for all our panelists, Dr. Jain and everybody on this session for making it so informative. We do understand that in the interest of time, unfortunately, we had to rush this up a little, but I'm sure that you appreciate this in the interest of time. Thank you very much. Moving further, the next session that we are getting into, ladies and gentlemen, is yet another very important one. And
Yes, and that is quite interesting. But before that, we just want to check how attentive is our audience, right, Kanishk?
okay.
So let's play a.
All right, okay, done. चलो, तो जब तक हम यहाँ set करते हैं, sir, could you say yes? आप yes बोल सकते हैं? Say yes. थोड़ा loudly. You have just volunteered. Please come. इधर से. Is it? Please, please, please. Don't worry, don't worry. We'll just have fun while we are getting all this ready. Because this next topic, we want all of us to be back into action. Sorry, you were really, really comfortable. You know, I wanted to make you uncomfortable. That was the whole perspective of this. We'd be right here, sir. Don't worry. Okay, brilliant. Fantastic. What's your name, sir?
My name is Dr. Sainath Sitaram Bairagi.
Dr. Bairagi would be fine with me? Okay, Dr. Bairagi, I just found a friend in you, okay, and I forced you to be my friend. But I'll tell you why. So I wanted to choose a partner, and I chose Dr. Bairagi. Ladies and gentlemen, I would also be wanting each one of you to choose a partner. You see, you're here for networking as well, right? I want all of you to choose a partner. If you'll keep looking at me, how will you choose a partner? You have to either look at left or right somewhere, right? That's the only way you can choose a partner. For men? No, sir, no, come on. I mean, you're a medical fraternity. Let's not do that. You can always find, and it's okay. You can play with that lovely lady out there. It's perfectly okay. No, seriously, come on, yeah, you're a medical fraternity. Don't talk like that. Okay, everybody has a partner. If you have a partner, hold your partner's hand and raise this up. This is a very important exercise. This is the only way you'll get to know you're alone. See, you're alone. No, you can't be 3 people. You can be only 2 people, unfortunately. There are only 2 people on a team. That's another important factor. Okay, thank you. This was just to understand that we are not alone. Okay. Now that you're not alone, we want to get into this very quickly. And of course, this is getting us out of the slumber of the lunch. This is what we're doing. I want all of us to raise our index finger, please. Raise our index finger. Dominant hand. Right hand, dominant hand. Okay? And I want you to pull out your palm of the undominant, the left hand. Face towards your partner now. This is why you needed only one partner. Face towards your partner. Sir, मेरी तरफ देखो ना. हाँ, ऐसा. ठीक है? I want you to keep your finger on the palm of your partner. On the count of 3, it's a chicken 65 situation. Save yours, catch theirs. Save your finger, catch theirs. अपने में ही खेल रही हैं. That's why I told you cannot be alone. Okay, come on. Okay, on the count of 3, save your finger, but you have to catch your partner's finger. 1, 2, 3. You have to save yours. Okay. Come on, wake up, everybody, wake up. Okay, one more last time, huh? 1, 2, 3. Brilliant. Give yourselves a round of applause. Thank you so much, Dr. Bairagi, for playing with us. I'm sure that we are back out of the slumber of the lunch because this next topic that we're diverging into is the other side of the coin. You know, so far, we wanted to give you this perspective. So far, we've been talking about the women's side of things. But now I think it is time when we start talking about the men's side of things as well. And to precisely do this, we are going to be inviting our panelists. And I see our moderator is all set. So but I will go right away. Go ahead.
All ready with his, questions and everything. So now I would like to invite our experts for the panel discussion. Dr. Poonam Nair, Consultant Clinical Psychologist at Mata Chanan Devi Hospital, New Delhi, Infertility Counselor at the Akansha IVF Center. Welcome, ma'am. Now let's welcome our speakers with a round of applause. I think we all are quite energized and attentive, right? Dr. Vasundhara Jagannathan, Founder and Medical Director, Sri Chakra Fertility. Let's welcome her. Dr. Suttapana Samantha, Senior IVF Specialist, Krista IVF, Kolkata. Mr. Vakil Jagveer Singh, Clinical Application Manager, Cooper Surgical, India.
Dr. Samantha, sir, please.
And now to moderate this conversation with both clinical depth and emotional sensitivity, please welcome our moderator, Dr. Kaustubh Kulkarni, Founder, Director, Siddhi Life Assisted Reproduction Center, Mumbai. Welcome, sir. Over to you, Dr. Kulkarni.
Is the lapel mic working? Good afternoon, ladies and gentlemen. Thank you for making all of them active males and females.
Yes, that's important.
So the males have become active, thank you. So we start the discussion, and with the limited time that I have, I want to cover as much ground. Isn't it a paradox that for discussing what is predominantly a male-dominated issue, we just outnumber the women 3:2, but so be it. It means there's equality in everything. I hope the questions also get passed on to you. Can I have the presentation so that we can straight launch into it? And I'm sure this is just to make it visually rich. The point we have to make now is significant. You have your screens there, madam, in case you want to see. They're right there. We have audio-visually rich, as they say. So here we have something that is interesting. I'm sure everybody is aware of what WHO classifies as infertility. But what is more crucial for us is actually to judge whether we are looking at a uniform playing field, which unfortunately we are not. So let's be India specific. And what is interesting here is for you to note that this is data which came out before we say a lot of infrastructure got developed. So I would like you to pick up the message that most states seem to offer good help, but the medical help alone may not be the solution. Here's the lack of infrastructure in a state like Kashmir, where unfortunately, not having enough amount of infrastructure available, we were not able to offer healthcare services. So let's say a male need assistance. This is the essence of my slide. And therefore, just to take that point a little further, I have added another point here, which tells me that the three of us, guys, are more or less 40 to 50% responsible for what's going wrong as far as the infertility problem is concerned. So let's be honest about it, which is one of the things Poonam will answer for us as to the attitude. So here's the real numbers as we speak of, and as they say, statistics bails me out here by the numbers present. So having said that, this is data from 2015, which is about 10 years old, but most times that data is still applicable. So I think what I want you to now look at is a general overview of what is happening. And this is a nice, interesting slide where you try to simplify a complicated problem into one simple slide, which is again not happening, as they say, but it's good to highlight some of the major issues. Some of them are not India-centric. But having said that, I think we want to launch into the clinical side of it. So I see an even balance of clinicians, a lady and a gentleman, which makes it easy. So I would expect, Vasundhara, you to start, because as they say, ladies first. There is an anatomy which we need to talk of, and we're just checking how good you know the anatomy, as they say. The reproductive tract in the male.
Absolutely. Before starting the reproductive anatomy, I would want to say that, many of our IVF specialists are women, and whether we are really examining the male is a big question mark, whether we are comfortable doing that, because the cornerstone of diagnosis is based on the clinical examination and your history and only the semen analysis. In a female, we have lots of things, and all women are quite comfortable with male IVF specialists, but still, me as a gynecologist, I don't do it personally, male examination. And I have the luxury of having a uroandrologist in my center who does it. Now, when you look at Tier 2, Tier 3 cities, how many of our male patients, are properly examined to have the, insight into it, or they have the uroandrology specialty or a male gynecologist in their center? So it is very, very vital for us to have an understanding of the reproductive anatomy, and we know it is a pair of testes in the scrotum, and the testis is having like close to 250 lobules, and the lobules will have the seminiferous tubules, and then, from there the sperm is transported, the production starts happening, and then the epididymis again is the storage, maturation site, and also where the motility happens, and the temporary storage of the sperms also happen there. And then, they have to kind of move from there to the vasa deferens, and then the prostatic urethra, and the, membranous urethra, and the urethral meatus. With this, we also have to have an understanding of the accessory male glands like the prostate and the seminal vesicles and the bulbourethral glands, which contribute to the seminal plasma, which is very, very important because of the constituents and because of the fructose and other enzymes that are very, very important in the functionality of the spermatozoa. And also very vital in understanding is the scrotum is at a 2 to 3 degree lower temperature compared to the rest of the body. And that's very, very important for the spermatogenesis to be at a proper level. And the dartos muscle and the cremasteric muscle again helps in, maintaining the scrotal temperature during different temperature surroundings, whether it's extreme heat or cold temperatures.
So you covered a major area which I think needs to be highlighted as a clinician. Yeah. And I would like to take this a little further with the other clinician on board. So Dr. Samantha, Shotapa, I would like you to look at what is called as the least common denominator. I've put it into the slide. If you can read it, it is at the end of it, a miniaturized concentrated mass of haploid nuclear material with its own transport mechanism and locomotive power. Now that's a nice way of summing it up all and saying it means a sperm. So I would like you to just look at the least common denominator, and as has been said by our previous panelist, it is something which is a conundrum. Can you elaborate?
Yes, sperm actually depends on the structure. It's as a head, neck and tail. Head has DNA material concentrated in the nucleosome part. It has a capsid that is responsible for penetration of zona pellucida part of the human oocyte.
Correct.
And neck contains the mitochondria that is responsible for its energy, and tail contains the motilin that is responsible for the motility of the sperm to reach in the female oocyte part. So integrity, structural integrity is necessary for optimum outcome, be it natural cycle or be it IVF or ICSI for sperm selection.
Correct. So what you're saying is the male gamete is that specially endowed cell which is like a lean, mean fighting machine. That's a nice way to carry it home. And then you say that it has its own mechanism. And here are some demonstrative slides. I'm sure all of you are smart enough to have your own interpretation, but this tells you a good story. What you have to remember is, like they say, this is like the BrahMos missile. Please allow me the liberty to say that, Dr. Talwar, from the military parlance. But this guy has got a mean function, and there are many of them going. So if I may show you an actual picture on an ultra microscope, and then look at the gentleman who looks at the numbers of BrahMos we have. Dr. Jagveer, would you like to?
Yes, sir. So I think before coming to the numbers, sir, because I have a different take on semen analysis,
please.
because from last 10 years I am into trainings, and the one request which I always get is to train people on semen analysis. And I always ask them, ma'am, you are a tertiary care center in IVF. Why do you want me to train your staff or embryologists or junior teams on semen analysis? Then they will say, nahi sir, standardization nahi hai. So I'll come to that. So from a basic biology point of view, sir, to diagnose a female partner, we have n number of interventions. So like diagnostics are there, we have surgical interventions, hormonal as well as, but for male, we are still dependent on one test. And when I train the embryologists, I always tell them that you're not looking just at sperm, as you mentioned. You are looking at a transport vehicle which is carrying the crucial information, which is supposed to go to the other body. And the selection ratio by nature in vivo is 1:10⁻⁷. So how we analyze the sperm will define the course of treatment in an ongoing ART cycle, whether it's in vivo or in vitro.
So it's a very nice way of saying we are judging an individual by the collective. It's like saying the Hindustani or the Bharatiya looks like this, and that speaks for one human being. There are some areas of commonality, but there is a difference. Is that what you're trying to say,
Yes,
sir?
yes.
That's very nicely said. But just for the sake of understanding, if you can see the screen, I'm sure what I'm trying to bring out through the slide is that it is ultimately the observer's acuity which will decide on the standardization.
So the one thing which I personally also feel, and I agree with all the requests which I get, is semen analysis in India is one of the underlooked tests, even at a fertility clinics as well. Many people may disagree with me, but I'll just give you one example. Here we are talking more about sperms.
Correct.
I'll just go through the volume part. I'll just take one parameter of the sperm, which is semen volume. We give the container to the husband. Go and collect the semen. They will go, okay, you collect the semen in the collection room thanks to the ART law, and put the container in the pass window, and then the husband will go. We receive the semen container. WHO suggests that the minimal volume has to be 1.6 6 ml. And it can go up to 5 ml.
Yes.
So which will be considered as between the normal volume. Less than that will be hypo, and more than will be hyper. How many of us, as embryologists, I'm asking my fraternity, how many of us are checking with the husband after they have collected the sample that is this the normal volume which you ejaculate while you have a natural intercourse? Why it is important? The volume plays a major role in vivo conditions. The semen becomes a coagulate when it's ejaculated in the vaginal canal. It stays there for some time so that the sperms can move through the cervix. The volume can be less because of psychological reasons. The husband may have come rushing from the work, from the shop, just to give the sample. And going back to the anatomy, the low volume can also lead to oligospermia. It could be situational, idiopathic, psychological oligospermia, because the husband just came rushing, he just ejaculated the secretions. Very high volume could lead to high prostatic excretion, high seminal vesicle excretions. Anything low or below, above the recommended volume can be a cause of infertility in that couple. I'm just talking about one parameter. If I go beyond each parameter, so that's what we are looking at.
So that's not only an interesting training, but my clinicians are trying to add something. In the meantime, madam, before we actually let this fly, have every one of you not only got up, but realized that the discussion is going somewhere. Put your hands together, please, ladies and gentlemen. Thank you. One of the most interesting discussions on this topic, and I'm happy we have this. Yes, Vasundhara.
So I just wanted to say that it's like, just like Mr. Vakil was saying, that we need to have a standard questionnaire for our couple before we collect the semen analysis. So all these questions are answered, and they're also educated about how to collect the sample and what is the correct method of collection. That's one. And second thing is, as we rightly know, that semen analysis is the single most important test. Now with the advancements of, CASA and lot of AI technology into semen analysis, I think we should train in semen analysis, staining for morphology, leukocytes. I think all those are forgotten science for this generation. I think the basis is to standardize and train in semen analysis.
Elucidation and pH as well.
Yes, absolutely.
Madam, I was told by somebody, a male, very wise, not necessarily very well versed in words, who said, the semen analysis, sir, mere liye Aadhaar card, passport, or mera ration card bhi hai. Which I think is a nice way of saying it, which is also one of the areas which now Dr. Poonam will highlight into bringing up. But before I reach there, this is just something, Dr. Vakil, you would have to look at. I mean, you want to give all kinds of Greek names, Roman names to things that look so goddamn simple. Why do you want to make it look something like stenoteratozoospermia? Where the hell is these Greek, shipbuilders or something? And then again, you're just saying the parameters are there. What actually bothers all of us as a male, and I speak on behalf of them, is that are we really telling them that they're good, they need to be good, or can they be made good? So I think we are coming to the question where technically you're just putting them into small compartment silos, if I may, and then again, are we giving them a chance? Because they look at numbers, they fixate to numbers. I'm sure you face this problem. So Poonam, my question to you is, working as a clinical psychologist and looking at the male, I was interested in knowing how much of sympathy, caring, but more importantly, communication important. Would you like to elaborate?
Actually, it's a very interesting discussion because in psychology, the major research has been on the women because the entire IVF process focuses on the female body. So I didn't know this was the same for your side of the story. But almost hardly 20% of the research is on the men. And even in the IVF center, when they come, they are very much marginalized. We just need the sample. After that, the focus shifts out. So as a result, they feel left out, they feel insecure, and they also feel like, I have no role in this whole process. Although, like you said, that they have the most vital role in the whole process.
At least half the role.
At least half the role. So with this feeling, they drift out of the whole process. The woman comes with mother-in-law, friends, so many sometimes alone, and the man is disappeared. What is the effect of this long-term, short-term? Is that there is a communication gap between the man and the woman. Absolutely. The woman has all the emotions. The hormones are affecting the embryo transfer anxiety, the waiting period stress, then the grief reaction. There's a huge emotional roller coaster happening in her. but the man doesn't know what's going on emotionally. So he says, look, I've given her everything. I've given her the doctor, the money. I've given everything. What more do you expect? So we've seen couples where there is a huge breakdown in communication arising out of this. That is why, later on, this can affect treatment compliance. It can affect treatment outcomes. And it's a very fundamental guideline now, world over, that just to now, men need to be taught how to speak. They have this masculine persona. They can't show their feelings. And biologically, by the way, you are the weaker sex. I hope you know that.
I agree with you. Please put your hands together, ladies first, and the gentlemen don't clap. That's against you.
So emotionally...
No, it's not about against or for, we have to learn.
Yeah, it's a fact. Lifespan is shorter, the fetal loss is more for the male.
Before you say anything more, I might be leaving the hall. Because that means I'm the persecuted.
I should be exiting before
so
you.
Millions sperms required to fertilize one.
All we can say is we have millions, as they say.
Just to fertilize one.
So biologically, the lack of emotional expression rolls out into social isolation, inability to access social support, and long term is they start withdrawing from the society.
Absolutely.
That avoidance coping mechanism is very detrimental for their psychological health.
So if you want to have your patients go through more cycles, if you want them to both have a happy life as a bonded family, because the outcome of your IVF ideally should be to have a baby, you don't want to space out the couple, you want them to bring them together.
Yes, in fact, that's what they say. That's why you have to rope in the man for every session. They should be there, even if they have no biological role left after giving the sample.
IFS, you better start thinking of preparing a module to train males, which I think is the next creative area you can look at. So I'm going to go to something very interesting now. We will call this the intuitive test. And it's an interesting one because as you said, though we are the weaker sex, we believe we are the stronger one. And here's a very interesting way to look at it.
Okay.
And this is interesting because it's one of the ads I picked up and it's less than the copyright time. This is a typical male behavior. And at the end, we haven't hooked on the sound. It says men will be men. I'm sure all you have understood. Thank you.
Men will be men.
So if you know, this is, madam, one of the tests which is used by women who are smart. So I would like you to say, when this gentleman is told, you have what are called as bad numbers. Bad numbers?
Bad numbers.
Bad numbers. So Tapa, would you like to say what is bad numbers? And before she takes over.
Before I start talking,
Low sperm count.
Okay, so that low sperm count is something he takes personally. Can you tell us how you would like to address this gentleman?
Very personally, because there are reports that they start having erectile dysfunction after the report. And once, if the TESI report second is better, then the quality of life again improves. And many times, when there is absolutely zero count, then there is a feeling of loss of masculinity. Sometimes there's a cultural pressure that now this family lineage is going to be lost. There's a lot of pressure. So the only way which has been found very good for men is, first of all, getting them into conversations right from day one, making them part of the discussion so that the man and the woman learn to work together as a team. And they are able to provide, that is the core social support, so that they can face the society or the joint family together as a team, even if there is no male sperm. Most of the time, the women hide from everyone that it is the male factor. They said, no, it was my fault. They don't even tell anyone. So that is the level of stigma with male factor infertility. So the man also has to be prepared to get the support. It's a very vital source of support to create the husband and wife unity to work together as a team instead of getting counselors and so many external support. They are the ones who can bind together best. So it's worth the effort to make them work as a team. And then gradually, if work on their thought process so that they can have a different view of life, different goals, that there can be love and growth, even if the biological child is not genetically theirs.
So I'd like the clinicians now to come in. I'm putting up a slide for you to look at what are called as destabilizers of this factory. And I like to call it a factory because, and both my clinician friends would be more than happy to comment on each one of those points I'm making. Local injury, sometimes ignored, especially in childhood. Then you have ambient temperature, which has been highlighted before, substance abuse, which is another problem we are facing. You mentioned something, Dr. Vasundhara, about the accessory glands and their infection, stagnation of venous blood. This time, I'm going to let Dr. Sutapan take the lead and start talking about these factors. And can you say which one for you becomes an area of concern which needs to be addressed immediately? Of these ones which are there, you can look at them, you don't have to make a lead table of this.
Substance abuse, we can easily counsel the partner so that it can improve your sperm quality and you can have natural pregnancy or whatever. Then for pollution, we can also address that easily. For
microplastics and everything, everything is getting polluted, including the food you consume. And I assure you, some of the males who seem to take millions of rupees worth of medication need not take it if they understood common sense preventive medicine.
Then early involvement of andrologist, friend or colleagues to evaluate the male partner, particularly for female gynecologist, has to be there as a clinician.
And I think if you look at the MAGI, male accessory glands, so sometimes in the semen analysis, you see a lot of leukocytes or patients get treated for multiple
Dr.
times
Vakil
of
will say they were round
semen
cells.
cultures. Semen cultures coming repetitively positive and antibiotics over antibiotics. I think these are the times where we should refer them to a urologist to see if there is any prostatic inflammation
so what
or
you're
infection.
Highlighting is a specialist comes on board.
Yeah, specialist comes to play. That is one. And when it comes to lifestyle changes, that has to be in concurrence with the dietitian, the psychologist involvement in de-addiction if he's substance abuse. So everything, it takes time.
May
it is
I
not
add a small point here?
Yeah.
The point I would like to make is there are many urologists who claim to be andrologists, but they are two different subspecialties.
Absolutely,
you have to be trained in andrology by doing time. I mean, removing stones from kidneys does not give you a celestial advantage over other people, general surgeons.
And
so there has got to be training, and you have highlighted it beautifully by talking about accessory gland infections and not to go indiscriminately firing away with antibiotics.
Absolutely.
Please proceed.
And also as clinicians, we should be able to first-hand counsel them about the semen analysis. For example, if all parameters are normal and there's just a 3% morphologically abnormal and the report says teratozoospermia, nowadays they have access to internet and they come and they say teratozoospermia and they're really worried, or they just see few agglutinations there in the remark and they come and they're really worried. So as clinicians, we have to first empower them and say that this is not an issue. Just a 3% and overall your semen analysis is normal. So it is on the onus on us before we send them to a psychologist and then,
That's a brilliant point you make. You're the point of first contact.
Yeah.
So you're the person who can instill faith into a male, and that would make you feel happier. Here's a small point I'd like to bring out because we're running short of time. And as they say, where can stress affect? And believe you me, there is a problem which Dr. Poonam more or less highlighted about the no count male, as they say. He goes through a huge human roller coaster. So if you give me a short answer, before he accepts mentally that either he's going to go for donor or for an advanced procedure, what are the special challenges psychologically that he faces?
See, a very fundamental aspect about the male psychology is that they are problem-focused coping method works for them. So if the psychologist has the very fundamental knowledge about the entire system and there's a good reason for them to understand that it's a biological problem, it's not a threat on their identity or
Absolutely.
their masculinity or their life
or their
success
ego,
or
for that matter.
achievements.
Or their
they can
ego.
be, yeah. There are people who are hugely successful even ever without having a child.
Absolutely.
So that is a recreation of identity. And that is an in-depth process. It doesn't happen through one session. That is why repeatedly ASHRAE, ASARAM, IFS, we all highlight that the men have to be part of counseling right from day one.
Dr. Vakil, that brings me to the new point where, as they say, the technology supersedes the counseling, which is what shouldn't happen. Here's something that gets seen most on the internet. And would you like to highlight that?
So I'll start with Dr. Poonam's point. The male has to be involved in the counseling. So one thing which we were discussing, I'll just quickly finish. Just 2 lines and then coming back to the function test. Whenever a couple goes to a clinic, usually the wife is being called inside the gynecologist chamber and husband is sitting outside or being told to go to the andrology lab and collect the container. I think that is the point where we create the friend and foe bias in the mind of the husband, that there is maybe something wrong which is separately. Coming back to the advanced tests, I think this is the time we have to assess now. 10 years back, we were not sure about sperm DNA fragmentation, but now we have the measures to assess that. Earlier, there was only high advanced machines were available, but now we have kit-based tests are available. For all the ART specialists in the house, there are 2 books I will recommend you will have in your lab. Train your embryologist on that, WHO 2010 and WHO 2020 manual. Follow the reference guidelines from 2020. 2010 is how to do that test. And 2020 has a standardization and also talks about how DNA fragmentation can impact. DNA fragmentation impacts in a huge way, but we have to see which kind of ART treatment we're going for. So there is, sir, I'll just finish in one technical line.
You will have to appeal to the people who are running the show.
Morphology and DNA fragmentation. Just 2 parameters I would like to cover. There is a pyramid and reverse pyramid. Morphology has a prime importance when you do IOI because the sperm has to travel on its own. IVF, it is moderate. In ICSI, morphology assessment does not play a major role because you can deselect the sperm while doing ICSI. Parallel to that, the other pyramid is of sperm DNA fragmentation. If you are doing IOI, you can forget about DNA fragmentation in the initial stages because there is still natural selection involved if the count and morphologies are normal. But if you are more on ICSI, DNA fragmentation becomes a prime important test for you because you are selecting the sperm on the basis of its looks and how it works. And nature does not discriminate.
That's a fantastic point he's put together. Ladies and gentlemen, a good take home. Put your hands together for him. Lovely. You get an extra prize for that. Sutapa, I would like you to look at oxidative stress and what are we doing and what is happening? Is there something that we need or can do? That's probably going to be my last question because I'm running short of time.
Oxidative stress is a known risk factor for abnormal sperm parameter, and although routine use is not recommended, few things we can consider is because N-acetylcysteine, coenzyme Q10, or vitamin C, vitamin E, folic acid, zinc, and omega-3 fatty acid. So this we can use judiciously in selective patient, and in few reports suggest that it can improve clinical parameter and IVF outcome.
Dr. Vasundhara, would you agree? Giving it collectively and making it work in a collective manner, the antioxidants, plays a better role?
I think we need individual components to work on because now we have an array of pharmacological products having all-in-one combination.
Yes.
And we have the MOXIE trial, which is not proving much benefit if we use in patients who are having oxidative stress or DNA fragmentation elevated. It's not really working. So I think probably we have to look into individual components, whether it is working in reducing your DNA fragmentation or whether it's improving your concentration motility, rather than giving all-in-one combination. I think that is the thing, along with your lifestyle changes. And
absolutely.
If there is
I was about to ask you.
If there is a grade 3, grade 4 varicocele there, or if there is an obesity, uncontrolled diabetes, I think all these are going to...
If a guy is told there is a pill for your problems, he thinks it is a pill. And then if you tell him his lifestyle is a problem, he starts altering it. Here's a lovely picture drawn by a child who was born of IVF, and therefore I don't know, my time's up as they say, and I suppose I can close with these 3 or 4 slides because it's more or less a situation which requires probably a day's conference, and I'm sure we will interact on this after the panel has shown that there's a way forward and there's a holistic way to look at it. I'm just going to show you that conventional IVF and ICSI are 2 different procedures, which is what I wanted to highlight. I also wanted the people to come in on board. So I'll just run you through the slides, and I'm sure the answers is something you can catch up with our panelists outside, and they'll be giving you a situation where, as they say, everybody is happy. The people who want to ask questions can ask them outside. The ones who are outside can have their answers to their content. And my organizers are happy because I have finished everything. That was Professor Paul Devroy, my mentor, the first ICSI baby in the world. And as they say, coping with IVF is not an easy thing to do. Ladies and gentlemen, an absolute privilege to have a crowd in this afternoon. Wonderful, sure, and thank you to my panelists.
Thank you so much, sir.
Thank you so much, sir, for that wonderful moderation and that amazing topic of discussions we got. So now I would like to invite Dr. Kaustubh Kulkarni to please come on stage and felicitate our experts. Dr. Poonam Nair. Let's have a round of applause for our experts. Dr. Jagannathan. Dr. Samantha. And Mr. Jagveer Singh. I would like to invite Dr. Professor Colonel Pankaj Talwar to please come on stage and felicitate Dr. Kaustubh Kulkarni for amazingly moderating this discussion.
Thank you. And we must say this was one of the most well-moderated session, of course, sir. Led very well. Thank you so much.